Dr. Savitri Srivastava, and Dr. S. Krishnan is the true inheritor of this grand legacy, which he actually diligently sprinkled over all amongst his students. He is magical in his interventional skills. Above all, he has capacity to inculcate right skills required for the diagnosis and intervention in the to read from his biodata. So he is master of all this, what I am just going to speak about, that is echocardiography, balloon valvuloplasty, non-surgical closure of PDA, stenting, venous channel stenting, stenting of aorta, great arteries, the closure of VSDs, post-MI infarction, balloon dilatation of atrial septum. It is a very important paper actually, file closure of PDA. So many first goes with him. I think interventional skills, evolution of the ASD device, PDA device. So he is one of the first person in India who started using them and who actually allowed them to grow. And of course, he also helped to generate a new set of pediatric cardiologists who can very smartly do those procedures. So coming to today's topic, that approximately 2 to 5% patient may have systemic hypertension, and 75 may remain undiagnosed. And whatever I am saying is a very underestimate of, because in India we really don't know what exactly count is. So because we are having better survival for the neonates, we are having better survival for chronic renal diseases, heart disease, and of course the change in lifestyle. So recently threshold of blood pressure, normal blood pressure has gone down because of publication of new normative blood pressure chart. So looking at all this, today's topic is very, very important. I would call Dr. Gaurav to say a few words, and then I will request Dr. Radhakrishnan to take over.
Good evening, sir. Dr. Radha, sir. Good afternoon, sir. It is difficult to say anything about Dr. Radha because he is the pioneer in the field of pediatric cardiology. I got trained under him. I request Dr. Radha, sir, to give a lecture on hypertension in children. Thank you very much.
Thank you, Smita, for those very kind words, and also Dr. Gaurav. As you very correctly said, Smita, this is a topic, or this is a subject which has been neglected. We keep on talking about hypertension in the adult population, but we have never broached this subject seriously, either in our clinic, or have we explained to the pediatricians the importance of hypertension. It is only now that when we are taking this area seriously, although there is so much of work to be done, and it is up to the youngsters and the pediatrician to take up this topic and work on it very seriously. So let me start with this. Is it important to diagnose hypertension in children? And the questions that need to be answered is, what is the rationale for identification and treatment of hypertension? We all thought that hypertension is a disease of adult life, but no more. We know that it is as important to diagnose hypertension in the pediatric population. But the question is, how do you define hypertension in children and diagnose it? In the adult population, there is one BP reading beyond which it is said that it is hypertension, but unfortunately in children it's a bit more complicated because they are actually growing and continue to grow till they reach the adult life. What is the recommended workup? What is the optimal BP goal? And of course, what are the long-term implications of not treating or neglecting this particular problem? So what is the rationale for identification? There is this, we have this International Child Cardiovascular Cohort Consortium, which was initiated to look into childhood cardiovascular risk factors and how they track into the adult disease. So it was found that childhood hypertension is very strongly predictive of adult hypertension. So this was very, very clear. If you notice left ventricular hypertrophy when we do echo or the ECG, it is an independent risk factor for cardiovascular event. This has been very well shown in the adult population, and now it is being gradually realized in the pediatric population also. An elevated blood pressure that persisted from childhood into adulthood was associated with an increase in carotid intima medial thickening. This basically indirectly means that the disease has already progressed on into the arteries because of the high blood pressure. Then in adults, microalbuminuria is a powerful predictor of both renal insufficiency and cardiovascular morbidity and mortality. And the prevalence of microalbuminuria in patients of hypertension is estimated to be 20%. And we have now started noticing microalbuminuria in children also with untreated hypertension and progressing on to renal affairs. So there is enough reason why we should look into this problem very seriously and start measuring blood pressure in the pediatric population. As usual, for lipid disorders, for congenital heart disease, and all these problems, we don't have our own epidemiological data, which is very sad. And I think it is high time that somebody takes up this topic. And I would recommend, especially the pediatric people, to take this topic and at least get us a firm epidemiological data on the prevalence and incidence of hypertension. So all these data which I am showing you are actually from the Western population. And the problem is, can we extrapolate it into our own population? We can't do that. So the various studies have found prevalence up to from 4.7 to 19.4%, which is a huge number. Prevalence of hypertension was found to be higher in Hispanics, that is in the US, and lowest amongst Asians. And the combined prevalence increases by nearly 5 times to around 30% in adolescents who are obese. I'll talk about this obesity factor in hypertension. So clearly, it is going to be a major problem in our country also. There is no reason why we are following the Western standards in terms of diet, obesity. All these problems are present in our own population, especially amongst the educated groups. And therefore, there is no reason why they should not be a problem in our country. What about the Indian scenario? As usual, it is always bleak. But there was one study which had come from the Department of Pediatric Cardiology and Biostatistics from Amrita Institute and published in 2009, where it was clearly shown that the application of international reference to Indian children that differ in various demographic factors may not be valid, which is true. We all know that. They have found a higher diastolic pressure for both sexes than international standards all across the age group, which is a bit worrying, and higher blood pressure values in Indian population are of considerable public health significance. So we have realized it now. Now it is time for us, I would say the youngsters, both in the pediatric age group and pediatric cardiologists, to sit down and try to get data on the normative data in our population, which unfortunately don't exist. So we try to copy the Western standards. In the adults, it is very simple. If your systolic BP is more than 130 or diastolic is more than 80, then you're hypertensive. That's it. There is no other confusion. There is, of course, some contradictions in terms of defining high blood pressure in adults. The American Society of Cardiology or American College of Cardiology has said that if you have a BP of more than 130 by 80, you're hypertensive, whereas the European Society of Cardiology still persist and say that It is only when it is more than 140/90 that you have to start worrying. So there is some controversy in that area between across the continent, between the US and Europe. Now, all these are based on normative data, and they have found that they have come out with the outcome data. So they found out that if your BP is more than 130/80, then your cardiovascular morbidity and mortality increases. But these are not available in children, even in the Western population. So because blood pressure is approximately normally distributed, instead of using a single value, they have found that if your blood pressure is more than 2 standard deviation above the mean, or roughly more than the 95th centile, then you define that as high blood pressure. So you understand that it is mandatory to find out what the normal distribution of blood pressure is, which unfortunately we don't have in our population, and therefore we copy the Western standards. And the approach used in children to define high blood pressure according to normative data and percentiles of BP are averaged over 3 occasions. And these percentiles are in turn adjusted for children's age, sex, and height percentile. Whichever of the systolic or diastolic blood pressure percentile is higher defines the BP category. Now, this is the 2017 American Academy of Pediatrics updated definition of pediatric blood pressure. If you look at children more than 13, you just follow the adult standards. That is, a normal BP would be considered systolic BP less than 120, a diastolic BP less than 80. But in a child between 1 to 13 years, you notice that it has been written that the systolic and diastolic BP should be less than the 90th percentile. Then there are 3 other categories for high blood pressure. One is the elevated blood pressure, elevated BP. Then we have the stage 1 hypertension, and we have the stage 2 hypertension, very similar to what they have proposed for adult classification. But here it is all based on percentile. So if you look at the elevated BP, it is said that if it is between 90th to 95th percentile, then it is elevated BP. Or if it is less than 95th centile or 120/80, whichever is lower. Then we come to stage 1 hypertension, where stage 1 hypertension is defined as a systolic and diastolic BP more than 95th centile to less than 95th centile plus 12. So in between these two would be stage 1 hypertension, whereas stage 2 hypertension would be anything which is more than 95th centile plus add 12 millimeters of mercury, and whatever the value would become stage 2 hypertension. So this is a bit complicated. One has to sit down and read it again and again to try to understand this. I'm going to show you a chart for an example of this. And if you look at the right-hand chart, they follow the same rules as that of an adult. So they are simple. You have just one cutoff point to define high blood pressure instead of going on to percentile. Now look at this chart. Here is an 11-year-old boy. First of all, the first thing that you need to do is calculate the height percentile. In which height percentile does that boy or a girl or whoever it is falls? There are separate charts for this. So for example, you have an 11-year-old boy whose height percentile rise in the 50th percentile range. Now, for him, the 90th centile blood pressure is about 114, which means that he falls under the normal BP category. His 95th centile would be 118. So if he has a blood pressure of 118, he falls at the 95th centile. So he becomes defined as elevated blood pressure. Now, between these, you have a value was 95th centile plus 12 millimeters of mercury, which comes to about 130. So if it is between 118 to 130, he becomes stage 1 hypertension. And if it is more than 130, he becomes stage 2 hypertension. So I think all of this pediatric group should have this chart, because it is impossible to remember these figures in the pediatric age group. So it is better that we have this chart in the OPD so that we can make a quick reference to this and then finally decide whether anything needs to be done. Now, this is a simple chart which uses the 5th percentile of the height for both boys and girls. And this is based on the 90th centile, which means that if these values are seen, they fall in the 90th centile, and therefore it is normal. This is for a quick reference, and you can see that as the age increases, the blood pressure gradually steps up till beyond 13 years, it has to be 120/80. So this is a quick reference chart which you can also have in your busy outpatient just to check whether the child is normotensive or is he going towards hypertension. And some of the studies have shown that if you have this value, then the negative predictive value of being hypertension is more than 99%. Definition of hypertension in neonate and infants is even more difficult. And therefore, there are not much data. Way back in 1987, the second task force on high blood pressure control in children had published this curve. I'm sorry about this. How do you measure blood pressure? The usual technique is the oscillatory method and oscillometric devices. And of course, there is this invasive method which we don't use in the outpatient. Invasive high blood pressure measurement is only in the cath lab or in a child who is in the ICU for some other reasons, a sick child where monitoring of the blood pressure is necessary. So typically, I don't have to say all this. The cuff has to be inflated about 20 to 30 millimeters mercury above the anticipated systolic blood pressure, and then deflated slowly at 2 to 3 millimeters mercury. Remember that these are all recommendations from the American Society of Cardiology. Prior to BP measurement, stimulant drugs or food should be avoided. This one is very important. Don't measure the blood pressure as soon as the child or the patient comes to the OPD. Let them rest for 5 minutes, and the child should be seated with his or her back and feet in a supported position. And in the infant, it is recommended to be in the supine position. So that is how much details which we have to do if we have to measure blood pressure seriously, whether it is an adult or a pediatric population. It is said that the right arm is preferred for blood pressure measurement. There are some reasons which are given, but then it is preferred to have the right arm for measurement. So these are some of the drugs which can be associated with temporarily elevated high blood pressure. So one might, if a patient turns out to be hypertensive, take this history and find out whether it is a temporary elevation or is it going to persist. Auscultation remains the recommended method of blood pressure measurement in children under most circumstances. And we all have heard of the Korotkoff sounds, where the 5th Korotkoff sound or the disappearance of the sound is used to define the diastolic blood pressure. In some children, the Korotkoff sounds can be heard up to 0. Under these circumstances, the BP measurement should be repeated with less pressure on the head of the stethoscope. And if it still persists, then we take the muffling sound as the diastolic blood pressure. These are all things which we all know about. We have been taught in the MBBS, and therefore I need not emphasize this. Now, this is a very, very important slide, and that is the choice of the cuff of the blood pressure machine. Unfortunately, most of us don't even have a proper cuff to measure blood pressure. Even in the adult population, if you see, there are 3 varieties of cuffs which are used for different arm circumferences. And this should be applicable to the pediatric age group also. So it is very important in your clinic, if you are serious about measuring blood pressure, to have a variety of cuff pressures in order to satisfy the arm circumference. So typically the length of the bladder is taken to be about 80% in the middle between the olecranon process and the elbow. You measure the arm circumference, and the length of the bladder should be more than within 80%, and the width should be about 40%. Again, these are standard teachings. Unfortunately, except in big hospitals, in our clinic, we hardly have the ranges of blood pressure, and you tend to use the same cuff for measuring throughout all the ages. Even in adults, we don't bother to change the blood pressure cuff according to the size of the arm circumference. But then this is very important, because if your bladder size is smaller than the arm circumference, then you tend to overestimate blood pressure and underestimate if it is too large. So these are the methods that are now available throughout, even in our country now, the oscillometric and the auscultatory. You're all aware of auscultatory methods. This is something which is very commonly done, and this is how we learned how to take blood pressure. But then now we have these new machines, which is based on the oscillometry technique, where the mean arterial pressure is determined and the systolic and diastolic pressures are calculated. Whereas in the auscultatory methods, you directly calculate the systolic and diastolic pressure. The calculation formula for oscillometric method are different for different machines. The good part about it, it is easy to use in infants and neonate, where auscultation can become very cumbersome because the child is usually wriggling. It is easier to use where continuous or repeated monitorings are needed, especially in a busy OPD. It is said that it tends to overestimate blood pressure, and all the normative data that we have at this present is based on the auscultatory technique. But now the American Heart Association or the American Academy of Pediatrics clearly also recommends the oscillometric technique for measuring blood pressure in your OPD or at home or in your clinic. So this can be a very good substitute for the auscultatory method, especially in infants and neonate, and also in young children. There is something called the ambulatory BP monitoring, which not many pediatricians would be aware of this ambulatory BP monitoring, but it is used extensively in adults. One of the most common causes where it is used is to differentiate between white coat hypertension and actual hypertension. So ambulatory BP monitoring is the monitoring of choice in order to differentiate between white coat and true hypertension. You wear this, it is like a 24-hour Holter monitor. The blood pressure is measured at half-hourly interval, and then you create a chart, and finally you analyze the chart. The criteria for blood pressure monitoring by ambulatory blood pressure monitoring is slightly different from the chart which I showed. So it is said that if your mean ambulatory systolic blood pressure is more than 95th centile, combined with a systolic load of 25 to 50%. Remember that all this are computed by the machine and it is displayed in your final chart. So, or the daytime diastolic blood pressure of more than 25% plus nocturnal systolic load of more than 50% has been shown to have a 92% specificity for predicting secondary hypertension. So you don't have to calculate the mean ambulatory systolic blood pressure. It is all given there in the chart, the final chart, which is created after the BP is analyzed. All you have to do is try to find out whether it falls beyond the 95th centile or it is less than the 90th centile. Now we are going to talk about the management, which involves diagnosis, evaluation of etiology, and treatment. The evaluation is based on a good history and physical examination and of course investigation. The purpose of it is to identify secondary hypertension. I'll come to the cause. The second thing is to identify target organ damage. And finally, identify additional cardiovascular risk like obesity, dyslipidemia, and diabetes mellitus, all of which has to be treated in order to provide a complete care. So can we differentiate between primary and secondary hypertension? Usually we can take a clue because typically primary hypertension is diagnosed beyond adolescent age. Typically the patients are overweight and obese. There is a positive family history and they are usually asymptomatic. Whereas secondary hypertension is usually seen in the prepubertal age. They are usually at an advanced stage. Family history may or may not be positive, and you have the symptoms of the underlying disease. Now, what are the underlying disease? Remember that coarctation of aorta, then what do you call them? Adrenal diseases. These are all very rare causes of hypertension in the population. The first thing that we think about hypertension in a child as a cardiologist is coarctation of aorta, which is very wrong. Or you think of pheochromocytoma. All these are not very common causes of hypertension in the normal population. The most important cause, if you notice, between 1 to 6 years or 6 to 12 years is renal parenchymal disease. When we say renal parenchymal disease, it is not renal artery stenosis and all, because these are all dramatic presentation. But renal parenchymal disease remains the most important cause of hypertension between 1 to 12 years of age. And as we said, after 12 to 18 years of age, of course, essential hypertension takes over the most important cause of hypertension. And then, of course, renal parenchymal disease becomes number 2. And then after that, it's renal vascular disease, endocrine causes, coarctation of aorta. So in a normal population, when you see them in the OPD, please, it is not coarctation of aorta or pheochromocytoma which is causing this. You have to investigate in depth renal parenchymal disease in these group of patients. So a thorough history, including a history of sleep disorder, because it is now realized, especially in the adult population and gradually in the pediatric age group also, that sleep disorder is something which is very common. And there is a strong association of hypertension with sleep disorders, obesity, family history of hypertension, and other risk factors like lack of physical activity, unhealthy diet, smoking, and alcohol, which is also becoming more and more common. We tend to ape the Western population. And then, of course, in order to identify secondary organ damage, you have to take history of headache, vomiting, seizures. These are all very advanced stages of hypertension, but all these history have to be taken. Physical examination, again, we come to the fact that obesity remains one of the most common causes of hypertension in the population. So we have to calculate the body mass index. Then, of course, as a routine, at least in the first time when you see them in the clinic, you have to measure BP in both arms and right leg, look for presence of radiofemoral delay, look for presence of abdominal bruit, etc., so that you don't miss some of the very, very treatable causes of hypertension. There are certain laboratory evaluation of hypertension. These are basic evaluation for comorbidity, and of course, evaluation of end organ damage. At least in the first visit, all these things should be done so that we have a basic workup of a child who has been diagnosed as hypertension. And then you go on to additional evaluation, which depends on what your initial evaluation is. Renal scan, for duplex study, for Doppler study, MRA, then CT angiogram, arteriogram. These are all very advanced screening depending upon what you find in your basic cardiovascular evaluation. Then, of course, if you're suspecting pheochromocytoma, plasma and urinary metanephrines and plasma and urinary steroids. I have yet to see a pheochromocytoma in these 20 years of practice, but at this institute as a cause of hypertension. But I'm sure the endocrinologist probably might be seeing more of this. For me today, in an outpatient, either obesity or renal parenchymal disease remains one of the most important cause of hypertension in the pediatric age group. Of course, once in a while, being in a tertiary heart center, we do see coarctation of aorta, but that's a different, separate subject by itself of discussion. Once in a while, we also come across this disease called autoarthritis, which is probably much more common in the pediatric age group as compared to the other renal artery stenosis, which is because of fibroelastic disorder. And this is a very frustrating disease to treat, but one has to be very, very alert to the possibility of autoarthritis, especially in the female population, in order not to miss this. This is an example of coarctation of aorta. All this can be diagnosed by thorough clinical examination. You don't need a tertiary level care in order to diagnose coarctation of aorta. Simply feel for the brachiofemoral delay and you will be able to diagnose coarctation of aorta. Remember again, I am emphasizing in a normal population, it is not coarctation of aorta which is a common cause of hypertension. What about the management? You have the non-pharmacological measures and pharmacological measures. Non-pharmacological measures may be the only treatment that is necessary, especially something in stage 1 or just elevated BP category. But pharmacological measures should always be associated with non-pharmacological measures. They are not separate from each other. And whenever you're using pharmacological measure to control blood pressure, the non-pharmacological measure should continue together. Whereas in the early stages of hypertension, the non-pharmacological measures may be the only ones that is necessary in order to control blood pressure. So it is recommended in the non-pharmacological therapy, again, weight reduction in obese patient is of the most important recommendation in order to control blood pressure. We keep on emphasizing this to the parents that you have to reduce your blood pressure, otherwise it's going to lead to all forms of heart disease as they track into adulthood. Regular exercise, we keep on saying this to the parents, but for most children today, the exercises are restricted to cell phones or Netflix and all these things. This is what is the most important, but we have to emphasize to tell them to participate in outdoor exercise activity. Dietary modifications, as far as hypertension is concerned, it's a good idea to practice as little as salt consumption as possible so that it becomes second habit. Stress reduction is easier to say than it is practiced. And then, of course, definitely treat dyslipidemias, counsel against smoking, alcohol intake, caffeine, and of course, energy drinks, which is so commonly used now in children who want to go to the gym. They are all ready to go to the gym, but they are not ready to do regular exercises. And this has become a pattern, especially amongst the rich. Pharmacological therapy, this is an unfortunate category that we land up into. Imagine trying to treat a small child or an adolescent with drugs, which is likely to be continued throughout life. And that is where prevention becomes a very important thing. So pharmacological therapy is definitely required in symptomatic hypertension, stage 2 hypertension, stage 1 hypertension, where all our efforts to modify the lifestyle has failed. Then, of course, hypertension, end organ damage, any stage of hypertension or high BP for patients with chronic kidney disease, and any stage of hypertension for patients with diabetes mellitus. What is the target guideline now? It is simple. Bring the blood pressure below the 90th centile for that particular age. and for an adolescent, less than 120/8. In chronic kidney disease, it is recommended to bring the blood pressure down to less than 50th centile, which can be monitored or done by ambulatory BP monitoring. So this is our target. In children less than 13 years, you have to bring the blood pressure to less than 90th centile. If they have a kidney disease, then less than 50th centile. The choice of the drug depends upon the underlying cause of hypertension, whether it is renal disease, whether it is coarctation, whether it is essential hypertension, concurrent disorders, and of course the preference and experience of responsible clinicians. So let me go through some of them. At present, for primary hypertension, ACE inhibitor or the ARB remains the first drug of choice, except for sexually active females, because these two drugs are contraindicated during pregnancy. If the target blood pressure goal is not met with the maximum allowable dose of the initial medication, whether it is ACE inhibitor or ARB, then one can add a diuretic to the drug regime. Remember that these are very broad recommendations, and for sexually active females, the calcium channel blockers could be the drug of choice as the initial hypertensive agent. For renovascular disease, calcium channel blockers can be used as an initial antihypertensive drug, but in CKD, remember that chronic kidney disease is not the same as renovascular disease. When we talk about renovascular disease, it means renal artery stenosis, where ACE inhibitors or ARB should not be used, preferably avoided. Whereas patients with chronic kidney disease, diabetes mellitus, ACE inhibitors still remain as the initial antihypertensive treatment of choice. So how many drugs do you have? In the adult population, you have a huge list of ACE inhibitors. Whereas in the pediatric population, we had captopril once upon a time, but that has disappeared from the market. So the only thing that is recommended in the pediatric population, and which is actually available, these drugs like fosinopril, benzabipril, lisinopril is still available. I have not even seen these medications in my practice. For us, or at least for me, enalapril remains the best treatment choice for if you want to give an ACE inhibitor to control high blood pressure. We have these drug regimes. I'm not going to discuss about the details of the dosages and side effects, because then that becomes too lengthy. For ARB, it is recommended that for the first 1 to 5 years of age, this drug candesartan, which is available in the market, should be started. After 6 years, you have the choice of more drugs like losartan, olmesartan, valsartan. All this is freely available, at least for the adult population. But as mentioned before, it is always better to stick to one particular drug which you are very familiar with. You are familiar with how to step it up, how to modify the dosage. You are familiar with the side effects, and therefore stick to one particular drug, because the drug company guy is going to bombard you with a lot of information about how to use these drugs, because he would prefer the choice of his company. But remember that all these drugs are the same if it can be tolerated, and if the blood pressure can be reduced to our target level, then there's really no difference. There is no class difference, so to speak, except in the first initial age, about 1 to 2 years. If you want to give an ARB, then you prefer candesartan. But if you don't want to give an ARB, of course, you have enalapril. And then, of course, calcium channel blockers can be easily prescribed in children of any age. Amlodipine is one of the most commonest type of calcium channel blockers, which we prefer on a day-to-day. Again, the other drugs like felodipine, isradipine and all, I have never used it. I have not even seen it. Nifedipine is something which we can use, but nowadays amlodipine is the most popular group of calcium channel blockers which we can use. There are three types of thiazide diuretics. Usually, furosemide is not preferred as the initial choice of diuretics in hypertension, unless they are in heart failure because of high blood pressure. Then, of course, one would like to start with much stronger loop diuretics. Otherwise, the thiazide diuretics are the much better choice, and it can be usually used in children safely. We have chlorthalidone, which has suddenly become very popular in the adult population. I have not used this many times. In fact, I have not used it in a pediatric population. We usually stick to chlorthiazide or hydrochlorothiazide for if you want to use a thiazide diuretics, and loop diuretics only when they are in heart failure also because of any reason. I've spoken to you about the calcium channel blockers. So in conclusion, ladies and gentlemen, hypertension and obesity in children are increasing in an upward trend. But I'm sorry to say, there is no data. This is just a feeling sitting in the outpatient, seeing these obese babies, obese children, and when you measure their blood pressure, it is actually high. But unfortunately, we don't have any data. And it is very imperative that these pediatric hypertension is recognized and treated because they are known to track into adulthood. It is advisable to measure blood pressure at every visit with the appropriate technique. In fact, as pediatrician, we would now recommend that any child who comes to you, whether for fever or for any other reason, at least one BP recording should be done in the outpatient department. And then subsequently, one can decide how frequently it has to be done. And as pediatrician, you're the first people who come in contact with these children. As a tertiary pediatric cardiology unit, we only see them once it is already diagnosed and not when it should be actually diagnosed in the normal population. It is important to encourage healthy lifestyle in all children, easier said and done in today's children and adolescents, and help institute lifestyle changes for weight reduction in overweight children. Again, the pediatrician plays such an important role because again, they are the first people who come in contact with these children who have terrible eating habits. They are all obese, and therefore we have to encourage them to lead a healthy lifestyle. Otherwise, this is going to become an epidemic in another 2 or 3 decades, just like we have a heart disease epidemic in the adult population. It is not very long, then we will be encountering these, just like diabetes has become almost epidemic in the adult population. Even in the pediatric population, it's not going to take much long for us to catch up with the adult population. Thank you very much for your hearing.
So, thank you very much, sir. Lucid presentation very well covered every aspect of it, and most important part is diagnosis, where proper blood pressure measurement is very important, which you actually detailed very well. Sir, there are questions like Dr. Pankaj Garg wants to ask. If I want to look for outcomes in children to define hypertension, what should they be in your opinion?
You want to look for?
Outcomes in children to define hypertension. What should they be in your opinion? Difficult, Dr. Pankaj Garg. Question समझने में थोड़ा.
Yeah, I'm having a bit difficulty. If you can word it in a different way.
हाँ, Dr. Pankaj.
Let me take him on the panel.
उनको panel, you can take him on panel maybe. And he also asked for beta blockers in management.
Dr. Pankaj, you can ask your question. You please unmute yourself and ask your question.
Dr. Radhakrishnan.
Yes.
Hello, how are you, sir?
I'm fine, thank you.
As you said that there are no known outcomes. So in adults, you said the outcomes will be the morbidities to define hypertension. For children, you said there are no outcomes which are known. So
No,
if
no.
we want to
What
do a
I meant
study,
was there are no outcome data that are
yeah.
available.
So if we want to do a study and we want to look at some outcome data to define hypertension in children, so what should they be?
Well, you have to have a normative data, Pankaj. Unfortunately, we don't have it. There was some little bit of study which was done in Amrita, but unless you have the normative data for our population, and that is true for everything, not even high blood pressure, we always tend to copy the Western population, and only then we can define in our population what is going to be more than 90th centile, what is going to be more than 95th centile. And then, of course, when we follow them up, we are expecting that untreated hypertension will have the same outcome as that of the adults. There is
Okay.
some data available which shows that if patient is hypertensive and not treated, and if you look at the carotid arteries, what is known as the carotid intima medial thickness, they are abnormal. So which means that the disease has already set in, the effects of the high blood pressure have already set in, and it's a matter of time when they will lead to other comorbid events like kidney disease or heart disease.
Right.
And, Dr. Pankaj, you can ask your another question also.
Sir, you said that there's a effect of height also. Once you were mentioning that the effect of height on blood pressure, the average you mentioned that was fifth centile, children who are on fifth centile, you showed us a chart. So does
Yes,
this height matters throughout the age group or it matters only for children? So maybe as of
up to
13,
12
14,
years of age.
yeah. After that, it
After
stops
that, we
getting.
follow the same criteria as that of the adults. That is a single value.
Okay, what's the reason for that? That in younger children, height matters as far as the BP reading is concerned. As you get bigger, it doesn't matter. So, is it some relation? Or is it just a statistical number?
Yeah, the actual reason is not known, but you know that as the children grow, as their height grows, as their weight increases, so does the blood pressure. If you look at the chart in a normal population, which I showed, there is a gradual increase starting from 1 year of age up to 12 years of age. At the age of 13, they reach what is known as the adult normal levels of blood pressure. Whereas in children, as they grow, the BP tends to increase till a certain limit, and that probably comes to approximately 13 years of age. And that is why they have taken this cutoff and said that after 13, you can use the adult criteria.
So
Okay.
is it related to pre-pubertal hormonal level, cortisone and all adding
Yeah,
up to?
all those, of course, contribute.
And sir, what is your experience about the hypertension in relation to coaptation of aorta, early treatment, late treatment? Sometimes the coaptation is fine, but still blood pressure remains. So, what are the criteria you will get that kind of picture?
There are no separate criteria as far as I am aware. So we would follow, if you are asking me what target BP should be achieved, most important thing is to relieve the coarctation. And now the data is very clear. The earlier you do it, especially if you can treat coarctation in infancy, they are very unlikely to require any blood pressure drugs to control. But as the age increases, especially when you try to treat coarctation in older children, in adolescents and adults, it is said that approximately 30% of them will still require blood pressure to control, blood drugs to control the blood pressure. The only
Can I
thing one
ask?
has to be careful
Yes,
is the
yes.
choice of drug. Before relieving the coarctation, one should not try to use the ACE inhibitors or ARBs. It is best to restrict yourself to beta blockers. But once when the coarctation is relieved, then of course you have the option of using the same drugs which is recommended for essential hypertension or chronic kidney disease hypertension. But
So,
if your coarctation is unrelieved, then do not try to use these drugs. Stick to beta blockers and quickly relieve the coarctation. That should be the main goal of treatment.
Thank you, sir. Sir, I have a question. Basically, I had a keen interest in knowing the BPs of the babies. And in most of the obese babies, I used to take the blood pressure. And I find in significant number, there were a higher BP in respect of the normative chart. But the problem real arises practically is of acceptance. Generally, in most of the cases, they don't accept that their baby is obese, and once I mention that they have a higher blood pressure, they definitely they are not going to accept. So
Yes,
how to deal with that?
we have the same problem here. I mean, especially in the northern part of the country, they feel that the more obese you are, the more healthy you are. You know, that is the problem. And then I think the onus is on us to convince them. What I would do is I would show the chart, your percentile charts that you have for the pediatric age group. I show it to them and say, look, this is where your child stands. So you better start taking quick action around it. I mean, that's the best you can do. You can try to convince them. I know it is very difficult to do that. And when they come back the next time, their weight is usually 1 or 2 kilos more than what you had advised
More
them.
than that, in lockdown period, it is more than that.
This is definitely a social issue, but we can only do our best in trying to convince them. And the other thing which you tell them that, look, you should cut off this diet, you should cut off this diet. The first thing that the mother says, कि मेरा बच्चा तो कुछ खाता ही नहीं है. So these are some of the responses which come out when you talk to them in the OPD. I guess you can only do the best thing that you can do for them.
Sir,
Okay, and
Dr.
sir,
Acha. Continue, please, Dr. Dinesh.
yes, are we expected to treat hypertension, or should I refer the babies to pediatric cardiologist?
No.
I'm expected to treat hypertension on my own, or should I refer the child to the cardiologist?
No, I don't think it is necessary. I think you should be the ones who are treating it, get familiar with the drugs and do it. You should only refer to them if you feel that you're not able to do your job properly. That means you're not able to control the blood pressure. But of course, one visit to the cardiologist is necessary in order to rule out the secondary causes of hypertension. Also, the pediatric cardiologist can contribute in looking at end organ damage, especially of the heart. And I also feel that it should be a multi-speciality care because, the kidneys are also affected by this. My own practice is when I see hypertension in the pediatric age group, and I'm sure that there are no structural heart diseases which are responsible. The first thing I refer is to a nephrologist because I know that this is one of the most common cause of secondary hypertension, or in fact, the most common cause of hypertension in the pediatric age group. So once I've ruled out coarctation, and I don't require much investigation to rule out coarctation, just feel the femoral pulse, and then I would take a very, very strong opinion from the pediatric nephrologist or a nephrologist in order to rule out. And you will be surprised that in spite of so-called normal ultrasound of the kidney, etc., many of them turn out to have renal parenchymal disease by more sophisticated investigation. But the common
One last question. Yes.
hypertension, which you see, so-called essential hypertension in adolescents, which you are dealing with, and also in children, if you don't find any other cause, you should be good enough, competent enough to check the blood pressure in your outpatient clinic and modify it accordingly.
So one last question.
Fortunately, in pediatric treatment, the number of drugs are very, very restricted. ACE inhibitors 1, enalapril, ARB 1, and calcium channel blockers 1. So you don't have to be confused with the number of drugs, at least.
Dinesh,
should
there are two
pediatric-
questions in question box. So are you reading them?
Just last question.
Yes.
Should the pediatric echo should be included into the line of investigations while diagnosing the pediatric
You
hypertension?
mean to say if echo should be done as an investigation? Yes, I think so.
So,
Because that tells us whether there is any end organ damage in forms of left ventricular hypertrophy and all these things. because you don't know how long the hypertension has been present when you diagnose it. So at least as a preliminary, an ECG and an echo should be done. At least an ECG should definitely be done, because that itself may be enough to pick up LVH. And of course, an echo, which is a much, much more sensitive and specific way to see whether there is the heart has been affected by the high blood pressure.
Thank you,
Okay.
sir.
So Dr. Sonia Mittal wants to ask, in an obese child, if weight is very high and if BP is higher than 95th percentile, can we wait for lifestyle measures to reduce weight or start on antihypertensive? As already discussed, it's difficult to convince.
Yes, I showed you the chart there. If it is stage 2 hypertension, which I said is more than 95th centile plus 12 millimeters of mercury, then of course one should not wait only for lifestyle modification. One should start medications, continue the lifestyle modification as vigorously as you would like to do it otherwise without hypertension. And then probably after a year or so, once the weight reduction is achieved, once good lifestyle modification, one might try to taper off the drugs after the patient has reached an ideal body weight, and then see whether the child still requires continuation of the medication. But for
So
stage 1 medication, or the one stage before that, only elevated BP, one should try at least 6 months of lifestyle modification. Also, lifestyle modification which the patient is likely to follow or the parents are likely to implement.
Sir, there is another question from Dr. Shruti. What would be the best time and date to look for microalbuminuria? At what stage and duration of hypertension can we expect it? A patient on NVAS, which also reduces proteinuria, how would you look for ongoing kidney damage while on NVAS? So there are so many questions in single.
I mean, as a preliminary investigation or a workup of any child with hypertension, I think this should be a part of the workup, especially urine examination, and which all nephrologists would recommend to do a urine examination to look at proteins, to look at RBCs, to look at casts. And actually, it is a part of workup of secondary hypertension due to renal disease also. And microalbuminuria, of course, can also be done during the same sitting in order to have a baseline value.
Dr. Pankaj Garg wants to know salt and hypertension, how to take iodine intake in account.
Now, as far as salt restriction is concerned, there was a time when we first were training, it was said that one should do a salt-free diet. That is not necessary. There are recommendations which are provided. One would typically put this as moderate salt restriction. What I tell my patients are to restrict the salt to a level which the food is palatable, and every member in the family should follow the same pattern. It is not that you are eating lot of salt and but you want to segregate the child from that. That typically doesn't work out. The second thing I advise them is to not add extra salt on the table, the salt shakers as they are called. That should not be done. And of course, there are a lot of foods which have hidden salt, like preserved foods, all the ones which we are used to eating, pickles, biscuits, excess use of biscuits and all. They all contain hidden salts or in the form of sodium. All this should be restricted to as much as possible. The reason why too severe salt restriction is not necessary is that now we have very good drugs to control the high blood pressure. So to make it salt free is really not necessary. So the recommendations are moderate salt restriction. The way I put it, because it is impossible to measure by a tablespoon and do all these things. The way I put it is to restrict the salt to a diet which is palatable, and do not add extra salts, and cut off all these food items, preservatives, pickles, then the so-called namkeens, which contain so much of salt, and cut off all these things. This is what I give as a recommendation.
Dr. Gaurav Agrawal, please, you want to ask something or say something?
I just thank Dr. Radha sir for giving such an excellent talk on hypertension in children. I thank IIP North Delhi for giving us opportunity for hearing Dr. Radha. And as we all know, the kids are more engaged in mobile games nowadays. Like PUBG, although it has been banned, but we should try to console our kids not to engage so much in the mobile games, and we should force them for outdoor activities along with lifestyle modification. That is utmost required, and we should rely first on these type of things besides jumping on the pharmacological therapy. I thank Dr. Radha sir, and I thank IIP North Delhi for providing us such a nice lecture by Dr. Radha sir. Thank you very much.
Dr. Radha, I want to inform.
You should also advise the parents to stay away from the mobile phone, because you can't do it in an isolated way. The whole family has to change this bad habits nowadays.
Yes,
that's the only way when we can control them.
Sir, North Delhi is very unique in its approach towards the all lifestyle diseases. I would like to give a word of admiration for the group. They have actually, probably they are the only one who developed walkers group in morning, and probably they have walkers club. Probably Dr. Dinesh maybe speak about that. And that is a wonderful initiation at the level of pediatrician. And they also have marathon winner amongst themselves, Himalayan marathon, I think, Dr. Vineet Sehgal. So, Dr. Dinesh, tell us about your experience.
Thank you, ma'am. Yes, we as a part of North Delhi have started, apart from the academics, the non-academic things, in which we say it as sports and lifestyle club or sports and happiness club, in which we do a lot of activities. In the morning, Dr. Nagendra is there and he's very active. And people here almost goes for a walk and they compete among themselves. And last month, Dr. Nagendra has completed almost 400 kilometers in a month. He has walked 400 kilometers in a month. So that comes out to be an average 13 or 14 kilometers per day. Besides that, now we have started a cycling club also. And every Saturday, we go on cycling. Almost 20 people are there into the cycling club, and we go almost. Last week I was also there, and we drove almost 40 kilometers on cycle, through all these rural areas. Besides that, we
also participate in this.
So most welcome. Anybody is
most I'm asking the children also participate.
Yes, sir. Yes, sir. It is a family club, and we involve even spouses also and the children also. But obviously, yeah, Dr. Pankaj is there. He's
I just
also
want to add that apart from academic activities, we also conduct regular sports meets. Even last year, we did competitive sport meets between all the members, and we had competition for 400 meters and 800 meters and long jump. So just like school going children, just like collegiates, there around 50 people participated in all those events. So just to promote sports into a day-to-day activities. And I'm very happy that IIP North Delhi has taken this initiative. And that is why it makes us healthier, and our kids also join us in most of the activities. Thank you.
There is only one recommendation. It's a very good thing. One big recommendation I have is to try to bring out a normative data. Whoever does that would be doing a society a big favor, whether it is for lipid profile in children or high blood pressure. I mean, defining the normative blood pressure. One of you should take this up, and I'm sure ICMR would be ready to fund this without hesitation. I mean, this is one of my own plea.
As an organization, we are always ready, but we need a guidance with the key people like you, sir. And we
one
are
of the best person to guide you on this. Dr. Smita must be knowing Dr.
Dr.
Prabhakaran. Smita,
I have made, sir, one hypertensive registry. I did everything and chart changed. Like the normative, because I created a calculator, so it was easy to put your just height, weight, and everything will come. But then normative charts they changed, so that has happened. So we will try again to make a calculator for this. We
the
are
best
trying to
person,
then.
the best person to help you in these sort of population studies, Dr. Prabhakaran. You must have heard of him.
Yes.
Yeah. So Dr. Smita knows him, and she might help you to go and meet him and find out what is to be done. And that is the biggest favor you will be doing to the community, trying to bring out these normal data. In adults now, there has been a conscious effort in trying to get normal data in adult population for various cardiovascular parameters. And unfortunately, in the pediatric age group, it is still lacking. Of course, even in the West, the pediatric age group was always lagged behind. For example, it is only in 2017 that we have the recommendation on how they define high blood pressure, when to treat them, how to treat them. Whereas for the adults, it's been more than 4 or 5 decades since they have been doing it.
Sir, thank you very much, Dr. Radha, sir. It was wonderful listening you after such a long time. I had a good time with you and learning more. And thank you, Dr. Dinesh, Dr. Shalini, always ready to create some interactive movement. And I want to remind everyone that we are going to have our clinical meeting tomorrow, 17th. So please join that. And thank you very much. Thank you, Dr. Gaurav.
Thank you, ma'am.
Thank you very much.
Ma'am. Besides that, obviously we have a clinical meet tomorrow. But day after tomorrow, we have a very special event, that is the e-Permacon, our specialty meet. And I should tell you that we have got more than 700 registrations till now, and which includes almost 50 international registrations also. So 50 international people have joined.
Congratulations for such a wonderful registration.
Congratulations.
Thank you. And we are closing the registration at 5 p.m. Today itself. So those who have registered as yet, I request all of you to kindly register. Thank you. And thank you, Radhakrishnan sir. Thank you, Smita ma'am. Thank you, Dr. Gaurav.
Thank you, Shalini. Very quiet. Last word.
Just listening to you, sir. It was a very nice presentation. I thoroughly enjoyed, sir.
Thank you.
Thank you.
Okay.
Bye-bye, everyone.
Bye-bye.
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 Bye.